All right, so we're moving on to talking about etiology or the development of disease as well as the pathophysiology of the disease. So what's happening physiologically as the disease progresses. So really the question we're trying to answer is what causes diabetes? And if you already think you know, I'd love for you to jot something down at this point. Oh, okay. So I showed this at the end of the last lecture, I believe. But, right, these diseases are fairly tightly connected. So obesity and type 2 diabetes, right? You should be familiar with obesity enlarging fat cells, which can cause insulin resistance, which directly causes type 2 diabetes. If you have type 2 diabetes, you typically see blunted satiety responses. So often increased appetite, which can increase overeating, which then further increases obesity, right? So pretty vicious cycle. Again, you should be familiar with this disease progression, right? But right now we're really talking about this connection between, right, that positive energy balance leading to adiposopathy, causing insulin resistance, which then ultimately results in high HbA1c. Okay. Dyslipidemia definitely comes in a little bit too, but I just don't overly focus on that in this lecture because we're going to focus on it a little more when we talk about cardiovascular disease. So first, what is it? So we have two types, right? We have type 1 and type 2. This is just a cross section of your pancreas. Okay, so you can see, right, we've got beta cells, alpha cells, delta cells in the pancreas. So just to give you a little bit of context, right, that the pancreas does more than just secrete insulin. So alpha cells are responsible for secreting glucagon, which results in mobilizing glycogen and also encouraging the liver to make sugar from from fats and proteins, so gluconeogenesis. You have the delta cells, which release somatostatin, which inhibit the release of insulin and glucagon. So just both, right? We're inhibiting the alpha and the beta cells with the delta cells. And the beta cells are primarily responsible for secreting insulin. So in type 1 diabetes, we have what's called T cell mediated destruction of beta cells. So there's an autoimmune response happening where the body is attacking the alpha cells in the pancreas and it causes the body to not be able to produce insulin. It can be caused by enteroviruses as well. So the most commonly known one would be like polio, right? Which we theoretically have eradicated. So there are other enteroviruses as well, but in any case, it looks like sometimes infection can be a stimulus for the development of type 1 diabetes. And that can be diagnosed at any age. It used to be that we would call it juvenile onset, but I know personally three people who have been diagnosed with type 1 diabetes. One was as a child. I think he was young when he got diagnosed. I forget how old he was, maybe like 5. I know someone who got diagnosed while they were an undergraduate, and then I know someone who was diagnosed while she was a professor at the U. So you can see you can be diagnosed at any stage. So sometimes we think of it as young children being diagnosed, but that's not actually always the case. And then we have type 2 diabetes. And type 2 diabetes is characterized by insulin resistance specifically. So, right, type 1 is your body's just not producing insulin. Type 2 is progressively your body stops responding appropriately to insulin. So, in a normal process, right, we have glucose and free fatty acids, I might add in the bloodstream, right? Insulin then is secreted, right? And the body starts to pull that glucose, right, out of the blood. Okay, that's what we're seeing here. With insulin resistance, we see the body dumping more insulin in, but it's not pulling out much glucose. Okay, so that would be an indicator of insulin resistance, which means there's more glucose in the bloodstream, right? And therefore, our red blood cells are being glycated. So that's our hemoglobin A1C or our fasting blood glucose test, right? All of those tests would result or would catch all of this extra sugar in the bloodstream. Okay. Ooh. I already sort of talked about this, but this is just a normal response to insulin in the body. So, right, after a meal, blood glucose spikes, right, at about an hour. We've already seen that, and it should come down. Similarly, insulin should spike, right? It actually spikes just a little bit after that initial blood glucose spike. Okay, so 120 minutes after, and then that also should start to come down. What insulin is doing, right? So we've got this glucose in the bloodstream. Insulin is binding to a receptor, which then causes the GLUT4. This is in skeletal and skeletal muscle tissue and fat tissue, but insulin's binding here to this receptor, which causes GLUT4 to move to the surface of the cell membrane, which then allows glucose to enter the cell. There are other ways glucose can enter the cells, particularly in different types of tissue. So, for example, in the brain does not need insulin in order to um, remove glucose from the bloodstream. That's typically performed. I think GLUT1 receptors are the primary receptors there. So, lots of organ tissue in the body can absorb glucose without insulin, but skeletal muscle tissue and fat tissue are very sensitive to insulin, and it helps to move that glucose and the free fatty acids from the bloodstream into the cell. Okay, so you should already be familiar with this figure, so I'm not going to go over it too much. I just am going to highlight a couple of points. So first, right, you have to have that positive energy balance typically first, which then results in fat cell hypertrophy. With that fat cell hypertrophy, we typically see increased lipolysis, so increased breakdown of fats. However, this is our first spot where we start to see sort of the insulin problem coming in, right? So insulin usually leads to an increase in LPL and a decrease in HSL so that it will cause, right, those free fatty acids and that glucose to be removed from the bloodstream. However, with these increased inflammatory molecules, we see decreased LPL and increased HSL. So we have some conflicting mechanisms happening, right? We've got these cytokines, right? These inflammatory molecules that are giving us conflicting signals compared to what insulin is telling the body to do. Right? That's going to result in increased fat storage, which ultimately that fat storage, particularly in the liver, results in gluconeogenesis. So the liver starts making more glucose from fat and proteins because glucose isn't getting into your cells. And so the body then responds by saying, oh, clearly we need more glucose because our cells aren't being fed, which then results in hyperglycemia. Okay, so that's a direct cause of type 2 diabetes. You also see impaired immune responses, impaired mitochondrial function. You also see leptin resistance. Oh, that should have been hidden. Leptin resistance, right? So leptin would is secreted by our adipocytes, and it should help us feel more full. The body stops responding appropriately to leptin, which also then can contribute to increased inflammation and insulin resistance, ultimately causing type 2 diabetes. Now, this is the part of the lecture, right? We talked about the learning objectives where I want you to be familiar with some of the complications of type 2 diabetes, as well as sort of why does the physiology cause those specific symptoms and complications. So when the liver starts this gluconeogenesis process, right? So we're actually secreting even more sugar into the blood. We have glycosuria, so you have glucose in your urine now, which increases how much you're urinating because when the kidneys are filtering your blood, right, they'll actually end up pulling in some of that glucose. But when they pull in that excess glucose, what happens is water starts to follow it. So now we have more water being pulled from the blood. Okay, which results in polydipsia, which I don't know if I'm saying that right, by the way. I always used to think like professors must be saying these words right. And I'm like, sometimes I don't know. Like I've heard people pronounce them in different ways. So don't worry if you don't pronounce it correctly. Um, but ultimately, polydipsia is thirst. So I'm peeing more because I'm pulling more water into my urine because of that increase in glucose concentration, which means I'm pulling water from my blood, which means my hypothalamus thinks, oh, I need to then drink more. Okay. So I'm getting these thirst signals. Okay. That can result in weight loss, right? If you're peeing a lot more, you're actually losing water weight, right? Water weighs a lot and we're made up of a lot of water. So we can see weight loss as a result of that. Um, We also have a couple of additional complications that come with that chronically high blood glucose. So you have microangiopathy, which just means that I'm damaging my blood vessels, which makes them more stiff, which then decreases my body's ability to deliver oxygen and nutrients to tissues, which then can also impair my immune response and cause nerve damage and retinopathy. Nerve damage, right? Because if my nerves aren't being oxygenated, there's lots of reasons. Actually, I think I talk about, yeah, sorbitol. But you see increased sorbitol production, which then can directly negatively impact both blood vessels and nerve cells. So we see neuropathy, right, which is just sort of like death of nerve tissue, essentially, particularly in the legs, and then eventually can spread to your hands as well. And retinopathy. So we see destruction of blood vessels in the eye. That's also partly the result of sorbitol and that increased blood glucose. You actually see increased fluid being pushed out of the blood vessels essentially in the eye, which can cause blurry vision at first and ultimately can result in blindness. Okay, so that's more how type 2 diabetes functions. Now, this is how I hope it will play. Yeah, this is how type 1 diabetes works. I thought it was a funny video. So this is normal functioning rate. And now type 1 diabetes. What happens? Okay, so we've got that immune response knocking out those beta cells in your pancreas. Then your liver is going to respond by gluconeogenesis. Fat's going to respond by putting some ketones into the blood. And then muscle's going to respond by wasting away, which then also puts some increased protein in the blood. Okay, so you can see, right, different, very different etiology for type 1 diabetes. And we focus primarily on type 2 here, but I want you to be familiar with the differences there. Just for the record, there is actually slightly increased prevalence of type 1 diabetes in the US and also in Nordic countries. There are a couple of reasons for that. Dietary patterns may be influencing it. Vitamin D deficiency may influence it slightly. So honestly, from what I've seen in the literature, we really don't know for sure, but we do see increased prevalence. It still makes up a really small portion of the total cases of diabetes, but there may be some additional causes other than like the autoimmune response that may be genetic, and then also the enterovirus response that may be a result of that auto or may initiate that autoimmune response. So I hope that going through that chronic positive energy balance slide helped you understand why we wouldn't maybe see blindness. But one of the complications of type 2 diabetes is blindness, about 2 to 10% prevalence in individuals with type 2 diabetes. And that's just with vision problem, or oh no, that is blindness directly. 15 to 35% prevalence of just vision problems in individual with type 2 diabetes. So we can help mitigate vision problems and blindness by helping control blood glucose levels as well as blood pressure levels, right? So that those blood vessels in the eye aren't damaged as much. Kidney failure is a really common complication. So 20 to 50% of people who've been diagnosed with type 2 diabetes end up with kidney failure. And it accounts for 44% of the new cases of kidney failure. So diabetes is a huge problem in terms of its effect on the kidneys, right? We talked about the kidneys pulling in all that extra glucose, right? That does damage to the nephrons in the kidney. So right, sorry, I just said that. Increased flow, nephron damage, and then protein leaks eventually as well. Heart disease is the number one killer of individuals with type 2 diabetes. So any type of cardiovascular disease, protein glycation damages the endothelium of blood vessels, which increases the atherosclerotic process. And we'll talk about that a little bit next week. I think it's next week. Increased risk of stroke. So instead of cardiovascular, we're cerebrovascular, but for similar reasons, right? We could see increased atherosclerosis, especially with the increased blood pressure and increased dyslipidemia, which may be affecting how quickly plaque builds up, as well as how likely it is to rupture, as well as actually there's some evidence that suggests that clotting actually increases. Clotting factors increase because of that increased immune response as a result of hyperglycemia and dyslipidemia. So everyone could have a plaque rupture off of their blood vessel, but actually individuals who have type 2 diabetes are more likely to form a clot as a result of that plaque rupture. And then neuropathy and amputation, there's super wide variability in terms of the prevalence. So I saw really different numbers in different research articles, but 5 to 70% prevalence of neuropathy. It looked like lower for actual amputation, right? But maybe fairly high prevalence for just nerve damage, right? So pain in your toes and your feet and your legs, as well as in your hands. So for that reason, typically with exercise, we would avoid high intensity exercise as well as weight bearing exercise if we can help it. This is just an amazing slide and a great article on the complications of type 2 diabetes. So I encourage you to take a look at that if you have a minute. Another just really excellent depiction of the downstream effects of adiposopathy, or adiposity. So that essentially the downstream effects of increased or chronically increased positive energy balance. And I thought it was really great. So I'm not going to go over it. I've already gone over what I think is really important for you to know, but it's a great figure. So I wanted to include it. Okay, we're going to jump right into exercise for prevention and treatment. So for diabetes, outcomes could mean preventing new cases, right? We want to prevent the development of diabetes, delaying complications. So I just went through a huge host of like different issues that can be the result of diabetes. So how do we manage those complications? Or enhancing daily well-being. So individuals who are living with diabetes, how do we improve their quality of life with exercise? With that, which outcome for you feels most important? And does the answer change if you're thinking like a researcher, a clinician, or a person at risk? So I just encourage you to think about that, maybe drop an answer here. Also, because we're going to talk about exercise really briefly, I already talked about using insulin to treat type 2 diabetes, but just for the record, that is the standard of care for type 1 diabetes. You have to use exogenous insulin because the body's not producing it. But for type 2, as type 2 progresses, insulin is the standard of care. So there are other medications that can be used to help mitigate the effects of diabetes, but insulin is how we help people's cells get the calories that they need. There's long-acting and short-acting insulin. Long-acting, you typically take like once a day, but for short-acting, you may be taking as much as 5 times a day. So the type of insulin that you use dictates what your dosing strategy is. And that does affect exercise prescription. That's the only reason I bring it up, because 1 dose a day is really different than 5 doses a day. And if I'm working with someone, I should be aware of what their dosing strategy is. Okay, so prospective cohorts, we're looking at the frequency and the volume of physical activity here. So we had the US Physicians Health Study showed an inverse dose response relationship between type 2 diabetes and leisure time physical activity, independent of age, BMI, hypertension, family history, and smoking. So I really want you to pay attention to this. The age-adjusted relative risk for type 2 diabetes by PA frequency is 0.77 for 1 day a week, 0.62 for 2 to 4 days a week, and 0.58 for greater than or equal to 5 days a week. That should look like a very specific thing for you. I'm hoping you've already thought it while I was talking, but pretty clear dose response relationship with frequency of physical activity, right? I've got a 23% reduction followed by a 38% reduction followed by a 42% reduction, right? Then we take a look at the US Nurses Health Study, inverse dose response between type 2 diabetes and METs. So here they were looking at total physical activity, in the physician study, just at leisure time physical activity. And that's what's shown here on the right is, right, we see decreased risk with 1 day a week. With 1 day a week and then adjusting for BMI, we see still a decreased risk, but you can see, right, part of that is the result of lower BMI in individuals who are frequently active. The article that you're going to read this week reports a couple of numbers. So they split between high versus low total physical activity. So again, looking at all physical activity, so looking at occupational, transportation related, as well as exercise related physical activity. What they found is that when you compare people who are highly physically active versus low physically active, that the relative risk is 0.65 for high compared to low. So whatever that is, 35% reduction in risk for type 2 diabetes for individuals who are highly physically active. Look at that confidence interval. You should be able to interpret that for me. Then they also looked in that study, or you'll read it later, at leisure time physical activity, again, high versus low, and then the relative risk there. So also pretty interesting, not what I would typically expect to see. Typically, we see slightly stronger associations with leisure time physical activity. In this case, actually, it looks like total physical activity had the stronger relationship with incidence of type 2 diabetes. Also, higher frequency really mattered, right? But when you look at the article from last week, or maybe it was 2 weeks ago, right? And looking at those weekend warriors, particularly if people were not at risk for disease, actually weekend warriors were fine. So frequency starts to matter in really specific scenarios, it seems like. So especially maybe for high risk individuals, and this may be part of the reason, right? The confounding factor of type 2 diabetes. Okay, this was a great study looking at glycemic control and cardiovascular disease risk factors stratified by self-report in terms of frequency of physical activity. So self-report data, right? Age, male, diabetes, duration, all had significant associations with frequency. So PA0 means they were active 0 days a week, 1 day a week, 2 days a week. And this was, oh, by the way, this was type 1 diabetes. Okay. And what you see is that older individuals here, right, were more likely to not be physically active on any days of the week. We also see that males were more likely to be physically active on at least 2 days a week. And then that people who had diabetes for a longer period of time were also less likely to be physically active, or more likely to be inactive or active 0 days a week. Sorry. Really excellent articulation there. Then again, looking at p-values over here, as well as HbA1cs, okay? So for individuals who were not physically active or were physically active on 0 days a week, they had higher HbA1c levels than individuals who were active on 2+ days a week. You see the same thing. Insulin dose goes down the more frequently you're active. BMI goes down, overweight goes down, percent obese individuals goes down. Blood pressure not significantly affected here. HDL does go up the more active that you are significantly. Triglycerides also go up, triglycerides go down the more frequently active you are. Again, sort of looking like dose-response relationships here, although this wasn't assessed for a dose-response relationship, but it looks kind of like that. Also, percentage of retinopathy goes down with increased frequency of physical activity as well. Okay, so again, in type 1, in individuals with type 1 diabetes. These are forest plots. Now, I think you've seen these before, but forest plots just look at the different effect sizes from different studies. So this was a systematic review and meta-analysis looking at, I think that says 47, yeah, 47 randomized controlled trials with over 8,000 patients who had type 2 diabetes. Uh, and the interventions had to be for at least 12 weeks in duration. Looking at my outcome of interest is HbA1c, and I'm looking at a difference between individuals who did aerobic training and who did no training. Okay, so in that case, my overall outcome was that there was a significant reduction in HbA1c, right? Again, look at the confidence interval, interpret that reduction for me. Again, here we're not looking at relative risk though. So remember, we're looking at a mean difference here. So mean difference, my null hypothesis would be that there should be no difference between groups. So now if my confidence interval crosses 0, I would say not statistically significant. Okay. Whereas, right, with relative risk, hazard ratios, and odds ratios, we're looking at if it crosses 1. Now we're looking at if it crosses 0. And we see it doesn't cross 0, so statistically significant reduction in HbA1c as a result of aerobic training. Similarly, with resistance training, significant reduction there, although you can see we barely hit that significance, but we did hit significance, which means still the chances of seeing this result, right? The chances of seeing this result are less than 5% if if my null hypothesis were true, that resistance training does not result in reductions in HbA1c. So pretty confident resistance training results in reductions. Combined training, which means I did resistance anaerobic training compared to no training, right? Also see statistically significant reductions. So I didn't compare aerobic resistance and combined. I just compared aerobic with no, resistance with no intervention, and combined training with no intervention. Overall, so now if I'm looking at roughly the reduction as a result of any kind of exercise intervention, this is what I get, right? So greatest reduction I'm seeing is in that aerobic intervention. And this study also found that durations of greater than or equal to 150, no, greater than 150 minutes per week were associated with greater HbA1c reductions compared to interventions that didn't reach that 150-minute mark. Again, really similar. So from the same study, looking at HbA1c weighted difference, this was physical activity advice with a dietary intervention. This was physical activity advice alone. What we see is with the dietary intervention, significant difference in HbA1c. With the physical activity advice alone, not a significant difference. Okay. Overall, interventions with advice only still resulted in reductions, but really I'm looking at that dietary component, it looks like. Okay. So, right, we've seen frequency and volume seem to share inverse dose response relationships. However, that also differs based on the population I'm looking at. So this is in the South Asian population, right? Which we said, right, is the diabetes capital of the world, essentially. So really high prevalence of diabetes at lower BMIs there, especially. What we see here is this is overall cardiometabolic risk profile. So they were looking at blood pressure, insulin resistance, and lipid profile, and they combined those three to say that that was their cardiometabolic risk factor profile. So to get reductions in the risk factor profile, South Asians had to exercise for 266 minutes in order to get the same reduction achieved by Europeans in 150 minutes. So not only do we have increased prevalence, increased visceral adipose tissue at a similar BMI, in order to get the same reductions, they also have to be physically active at higher volumes. Now, this was in South Asian men, so this didn't include women, I believe. Now I'm second guessing myself, but I'm pretty sure you'd have to go double check that article. But so this may not apply to women. I would be surprised if it didn't, though. So on that note, right, we said that there's higher visceral adiposity in that population. So insulin resistance is strongly inversely related to visceral adiposity, and visceral adiposity is strongly related to physical activity. So I'm just showing you that data here, right? We have insulin sensitivity. So insulin sensitivity goes down as percent central abdominal fat goes up. Okay. So, and that's independent of your risk profile for type 2 diabetes. We also see that, right, this is met hours per week. So my volume of physical activity, as my volume of physical activity goes up, my percentage of visceral adipose tissue goes down. Similarly here, we're looking at insulin sensitivity and frequency of physical activity per week. Okay, so as frequency goes up, insulin sensitivity goes up. As frequency goes up, fasting insulin levels go down, right? Which makes sense. My resting levels would go down. And because I'm more sensitive, I don't need to secrete as much insulin if my body's more sensitive to the insulin that I do secrete. Also, by the way, this was mechanistic study, right? Like we're looking at um, we're doing some pretty invasive measurements here that are pretty expensive. So this is the first study I think I've shown you today that wouldn't really be considered an epidemiology study. So this was done on 22 women, 22 women who were classified as overweight. But note that when you're studying mechanisms, again, right, when we have really intensive studies, we typically are going to, we're typically going to see fewer participants. Okay, so looking at the effect on this study combined the effect of exercise on HbA1c levels, insulin dosage, and CRF. And so I just summarized it here for you, but concurrent training does look like it's superior to aerobic when looking at all three of these factors. So we saw if we were just looking at HbA1c, aerobic maybe is superior, but if we're looking at HbA1c, insulin dosage, and CRF, that concurrent training seems to be the most effective. Just for the record, my guess would be that's because you're going to burn more calories because you're engaging in both aerobic and resistance as opposed to one or the other. High intensity does look like it's better than lower intensity. And I just showed insulin dosage data here, but this study had all three of them. So if we look at higher intensity compared to lower intensity, right, we see significant decrease in insulin dosage. Longer sessions, so whenever each session was greater than or equal to 60 minutes, we saw greater reduction in HbA1c, insulin dosage, and greater improvements in CRF. Higher frequency is better than lower frequency. That seems to be a pattern, right? We're seeing that pretty regularly now. And then longer duration interventions are better, particularly for HbA1c. So maybe not quite as much for insulin dosage or cardiorespiratory fitness, but interventions lasting greater than 24 weeks when we looked at the HbA1c data. So that consistency piece does seem to be important for health outcomes. Here, I'm going to let you do this interpretation mostly on your own, but now we're looking at a combination of risk factors. So we're looking at cardiorespiratory fitness and BMI and how that affects type 2 diabetes. So the risk for type 2 diabetes as a result of changes or as a result of your fitness status and your weight status. So I'd start with this one on the left, right? You should be able to tell, okay, what's my reference group? Start there. And how does that compare to my other groups? Then on the right, you have this further broken down into, again, look at who's the reference group, right? And then compare that to each of the other groups. And leave some comments here for your classmates too. Let's try to help everyone interpret this correctly, but I want to see if you guys can piece this one together on your own. So looking at PA volume and a dose response relationship, this is data from the study that you read today. So leisure time physical activity per 20 Met hours per week. You should have context for what 20 Met hours per week is, but that's a huge amount of physical activity. So if someone increased their physical activity by 20 Met hours per week, I better see a reduction in the incidence of type 2 diabetes, which their overall risk score here, they did in fact see. Then looking at per 5 hours per week, again, if someone exercises an additional 5 hours per week, I better see a reduction, which I do. And then this is them looking at that reduction in Met hours per week and then hours per week over here. And it looks like, right, we've got a dose response relationship in terms of reduction of incidence. However, it's really not I mean, it's not it is a very significant reduction. It's not as big as some of the reductions that we've seen in terms of mortality, but it looks like, right, relative risks to me look like we're hovering around 0.8. So I'm getting a 20% reduction as a result of being active 30 Met hours per week, or as a result of maybe 4 to 5 hours per week of physical activity. Also, remember, that's total physical activity. So light physical activity does count here. Then we wanted to look at volume, a combination of volume and intensity. So this was individuals engaging in high amounts of vigorous or low amounts of vigorous physical activity. When we compare the two, high amounts of vigorous physical activity had a greater reduction in risk for type 2 diabetes than did low amounts of vigorous physical activity. And we see the same thing with low intensity physical activity. So high amount of low intensity compared to a low amount of low intensity had greater reductions. So high light physical activity had a 34% reduction in risk. High vigorous physical activity had a 39% reduction in risk. So again, not directly comparing these two, but it looks like maybe vigorous physical activity is more effective at reducing incidence of type 2 diabetes. Similarly, that study that you're going to read today looks at type of physical activity. So on the left, we have occupational physical activity. On the right, we have resistance training. So occupational physical activity did result in a statistically significant reduction in risk, as did resistance training. So again, look at the magnitudes though. So the magnitude on resistance training as well as that confidence interval is pretty similar. Actually, the interval is a little bit larger, but similar for what it is in occupational. But then when we look at intensity, right? These are much tighter confidence intervals. This is a huge confidence interval. So the tighter the confidence interval, right? Also, the more confidence I have that, okay, yeah, there's definitely a pretty big reduction, and most people could probably expect a reduction, right? Because I'm looking at population patterns. Whereas my population pattern here indicates, hey, there's more variation there. Right? And if I look at these, right, the confidence interval could indicate, right, how much variation could I expect in different samples? So taking a look at those could be really helpful. And then lastly, looking at cardiorespiratory fitness and how it's predictive. So higher cardiorespiratory fitness does result in a statistically significant reduction in risk for type 2 diabetes. And you notice, I think that's the largest reduction that we've seen. So fitness does seem to be significantly um, reducing our incidence of a variety of diseases as well as mortality, maybe more so than physical activity. It might be a better predictor than physical activity is. In some ways, I think there's a good analogy to be made here between um, insulin and cardiorespiratory fitness, or HbA1c, right? HbA1c is sort of taking the average of glucose exposure over a 3 month period as opposed to immediate glucose, like present in the system in one moment when we're looking at that fasting blood glucose levels. Similarly, cardiorespiratory fitness may be looking at sort of, okay, how is general physical activity impacting us, right? That average of physical activity over time affecting cardiorespiratory fitness, as opposed to how's immediate levels of physical activity affecting risk for diabetes. So anyway, just some interesting stuff, but again, pretty wide confidence interval there as well. So to summarize, increased physical activity leads to decreased incidence of type 2 diabetes by 25 to 50% in healthy and insulin-resistant populations. That effect is reversible. So if you decrease your activity, your risk does go up. Looks like there's an inverse dose response relationship with frequency, intensity, time and duration I separate because I'm looking at time of each individual bout of exercise, so increased time, and then increased duration, meaning how long, like for what period of time were you able to consistently engage in activity? So we saw that greater than 24-week study there. Type, right? We saw maybe not a dose response, right? But we saw that occupational, resistance, aerobic, and combined training all resulted in significant reductions, as well as there did look like there was a pretty clear dose response relationship in terms of volume of physical activity and reduction achieved in incidence of type 2 diabetes. So, in terms of practical prescription, then how do you prescribe? There are some recommendations from ACSM. Frequency, the recommendation is no greater than 2 consecutive days without activity. So, again, looking at that frequency piece. Vigorous physical activity is better and results in greater gains in CRF and greater or improvements in insulin sensitivity. However, I would avoid that in individuals with retinopathy, right? So I wouldn't want to significantly increase blood pressure in individuals whose blood vessels to the eye are already significantly damaged. I also wouldn't prescribe by heart rate. So if I were prescribing aerobic exercise, I wouldn't do it by heart rate because many of these individuals are on beta blockers to control blood pressure, and they have a blunted heart rate response due to also nerve damage. So heart rate is not an appropriate way to prescribe intensity for this population. Time 150 minutes a week, duration greater than 24 weeks, progression slow with resistance training, partly because that glycation happens to lots of different tissues. So glycation of your tendons can make them a little bit more weak and brittle. So I want to give them more time to adapt as opposed to less. If someone has a resting blood glucose level of 90 to 250 milligrams per deciliter, we could say, yeah, they can engage in exercise. If it's outside of that range, we would say, okay, you need to wait. If you're really high, right, maybe you need to inject some insulin. If you're really low, right, we need to probably ingest some carbohydrate. Um, Insulin timing, you should avoid injecting right before exercise, right? So that's where I was talking about, right? If long acting, we're only injecting once a day, that might be less of an issue. But for that short acting insulin, if you're injecting 5 times a day, now that becomes more of an issue. And can Oh, sorry. If you're in terms of order of exercise, so vigorous or resistance training should happen before aerobic training, and it may reduce complications. So the reason, right, at the beginning of lecture, we talked about what happens during exercise. So exercise results in increased catecholamines and increased glucagon, which is going to cause the body to break down glycogen. It's going to engage in gluconeogenesis, putting more blood glucose into the bloodstream. So if that's the case, I'm not likely to experience hypoglycemia. Um, Whereas if you engage in moderate physical activity as opposed to vigorous, you're not going to see as strong of a response in that glucagon and catecholamines. And so I might not see the body dumping a little bit more of that blood glucose into the bloodstream. So with moderate physical activity, the risk for a hypoglycemic episode is much greater. Continuous glucose monitors can be useful in this population. Just a side note, I have a friend who studies blood glucose regulation in the clinical and general population. As far as the last time I talked to him, and it's not my area, but it is his, the last time I talked to him, the evidence, there was not evidence to suggest that continuous glucose monitors made a difference in health outcomes for healthy individuals. So a spike in blood glucose as a result of eating specific foods is not associated with negative health outcomes. That's what the current data suggests. So this whole there's sort of a movement like everyone should wear a continuous glucose monitor. There's just not data to support that. Okay, so lastly, and then we'll take a little break, talking about diabetes prevention program. Again, I want you to see if you can sort of puzzle apart some of this, but this was, I forget how many participants. It's over 3,000 for sure. I want to say it might have been over 10,000, but for sure over 3,000. Sorry, I should have that in the slide notes for you. Um, but the individuals in the diabetes prevention program had three goals: to lose 7% of their body weight, to reduce fat intake to less than 30% of their total calories, and to increase physical activity to 150 minutes per week of moderate to vigorous physical activity. So this shows whether or not they met those goals, and then what their mean weight loss was, and then also what the sample size was. Oh, okay. So actually, this was smaller than I thought. It looks like maybe we had like 1,000 or so here. In any case, I would love for you to take some time, try to figure out those, what that chart means on your own, what that figure means on your own. I think you're getting to the point where you can do this. Um, I'm going to highlight a couple of things for you. So people who didn't meet the weight goal, they did meet the exercise goal, they didn't meet the fat goal, right? They still had about a 44% reduction in their risk for type 2 diabetes. Okay, so these are individuals who don't have diabetes. It's their risk for developing diabetes. They had to be at risk, so their HbA1c had to be between 5.7 and 6.4, or their resting blood glucose had to be greater than 126 to be included in this study. Now, the individuals who were at their weight goal, right? So 7% body weight loss, they didn't meet a physical activity goal and they were at their fat goal, right? They had greater reduction in risk. Okay. This, by the way, this line is total risk reduction. So the solid line. The dotted line represents risk reduction when controlling for body weight loss. Okay, so that's saying this risk reduction is not the result of a change in body mass. So you can see, right, it looks like that sort of levels off at about maybe a 40% reduction, whereas we're getting this increased reduction as a result of a change in body mass. And you can see that the greatest reduction in risk was the result of people who met their weight goal, their exercise goal, and their fat goal. Okay. Um, Okay, I think that's all I needed to cover there. Maybe. Yeah, okay. We do cover it here. I just wanted to double check. So this is, there were two major studies that have both been unfortunately defunded by the current Department of Health and Human Services so this sort of started in Columbia at Columbia University. We'll see, maybe that funding will come back at some point, but these programs have been discontinued through Columbia at the very least. So initially we had the Diabetes Prevention Lifestyle Change Program, and we were comparing the effects of that to metformin and then to a placebo. And this is data from that. So first looking at weight change data, this is looking at changes in physical activity, and this is looking at medication adherence. So, right, we see pretty clear increased reduction in weight as a result of the lifestyle intervention. So that was a combination of diet and dietary intervention and physical activity intervention compared to metformin. Then looking at changes in physical activity, right, as makes sense, the counseling and one-on-one sessions that were happening during that lifestyle intervention resulted in an increase in physical activity. And then medication adherence is just a really interesting thing to think about, right? Just because you give someone medication doesn't mean they're using it. So it looks like we're hovering right around 70% adherence. And actually at year 3, people just that adherence rate actually dropped. And then also this is the adherence rate of people using the placebo. So slightly higher for placebo, interestingly, across time. Then we look at fasting plasma glucose levels. So notice that basically everyone here, so this is baseline, at 4 years, lifestyle and metformin were back to baseline levels. But we did see an initial decrease in fasting plasma glucose, whereas that placebo never saw that reduction. You just saw an increase in fasting plasma glucose. Then looking at HbA1c or glycated hemoglobin, right? Placebo just goes up and up and up. Metformin, slight reduction, then goes up. And then lifestyle reduction, it seems like we maintained that for a little bit longer before meeting up with right about where metformin is. Okay. Oh, by the way, it is 3,200 participants. So I was right, by the way, just to vindicate myself. Um, okay. And in terms of looking at cumulative incidence of diabetes, right, placebo group had the highest incidence of diabetes, followed by metformin, followed by lifestyle. So there was a 31% reduction in incidence of type 2 diabetes for individuals using metformin and a 58% reduction for those engaged in an exercise and dietary intervention. Then after that, so that was right 4 year period, so 96 to 2001. Then now they started offering the diabetes prevention program lifestyle change to everyone. So they offered it to even the placebo group, but they had a slightly more intense intervention for, so they added self-management classes, right, to that top column. Here they kept the metformin, and then here, right, they just started offering this to everyone. Again, that comes back to sort of the unethical piece. It's unethical to enroll someone in a study and not provide them at least the standard of care. And because their results were so successful with the lifestyle change program, that sort of became the new standard of care. So it would have been unethical for them to just have a placebo here. Um, this data is fascinating. This is our last slide, and then I'll give you a little break before we do a really quick mechanisms breakdown. But red represents metformin, and then green represents your lifestyle intervention. And this is across years. Okay, so there were 20 years of follow-up here. And what's really interesting is we pretty much see very little difference between the groups, right? But remember, this is now when everyone gets that lifestyle intervention. But when we get the lifestyle intervention and the self-management classes and the metformin, it looks like 20-year results maybe are not that significantly different. However, I will say, right, with systolic blood pressure, we saw much greater changes here. But even that placebo group at 10 years follow-up, right, for whatever reason, we saw much lower blood pressure values. Toward the end of the study, looks like they're much closer to even there. So anyway, one of the things that they talked about, though, is that in this 20-year follow-up, a lot of individuals were likely being treated by their physicians, so they didn't control for that because they couldn't ethically stop people, right, from getting clinical care. So a lot of these individuals were on blood pressure lowering medication as well as lipid lowering medication. And they think that, right, the placebo group as well could have been on those medications. The placebo group at this point could have also been getting metformin. They just weren't getting it from the researchers in the study. So huge sort of confounder here. But still, looking at 20 years of follow-up, it's helpful to sort of see like, okay, where are we getting the most benefit? In a 3 year study, right, that still is a finding that shouldn't be easily discounted, but no, right, okay, what's happening 20 years later and what are the confounding variables, right? So your interpretation of the data changes. Um, oh, this was also just interesting. Looking at cardiovascular outcomes, right? I told you that cardiovascular disease was the leading cause of death in individuals with type 2 diabetes. And what we saw is across the interventions, there was not really a statistically significant difference between cardiovascular outcomes in the three groups. And again, maybe because of the treatment that these individuals were receiving from their physicians. Okay, one little break and then last video.